hiker is very jealous, and he's or she is or they are always stopping my videos to slow me down, but still I'm not gonna give up and I'll continue my work. Also, I'm not gonna give up on retina surgery fellowship either at Saudi or at Italy. I'm not gonna give up, and I'm not gonna go to the side. Let me tell this happen. This group is very jealous of me and my work. Argon laser trabeculoplasty (ALT). Introduction. Application of continuous wave argon laser either bichromatic blue-green 454.4 to 528.7 nanometer or monochromatic green 514.5 nanometer non-penetrating coagulative bonds to the trabecular meshwork results in improved aqueous outflow. So argon laser, it comes in two forms, two colors, blue-green or monochromatic green. So blue-green wavelength is 454.4, 528.7, 454.4 to 528.7 nanometer, or monochromatic green, that is 514.5 nanometer, non-penetrating coagulative bonds to the trabecular meshwork results in improved aqueous outflow. So mode of action. Improvement of aqueous outflow is quite complex and yet not fully understood. Laser thermal energy is absorbed by pigmented trabecular meshwork. Possibly this causes increased spatial intratrabecular space due to shrinkage of collagen fibrils of trabecular lamellae and leads to increased aqueous outflow through the trabecular meshwork. Shrinkage of collagen fibrils also tightens the trabecular meshwork ring and opens up drainage pores. Rodriguez et al. Suggested that fibrosis induced at the laser site also results in inward moving of the trabecular meshwork and further opening of Schlemm's canal. Macrophages migrate into the treated area and engulf extracellular matrix. Laser-induced removal of the trabecular cells further stimulate formation of the extracellular matrix with altered composition to improve aqueous outflow. So, in short, what laser does is it alters the extracellular matrix and it enlarges the trabecular meshwork pores, also causes collagen fibrosis that pulls the trabecular meshwork inwards, that is towards the anterior chamber side, not the scleral side, towards the anterior chamber side, and it helps in opening up of the Schlemm's canal, and these things, they improve the aqueous outflow drainage. Then indications, obviously open angle glaucomas and not narrow angle glaucomas. So first indication is primary open angle glaucoma. Second indication is majority of secondary open angle glaucomas. So primary open angle glaucoma, inadequately controlled with maximum medical therapy with poor patient compliance as a prior choice to filtration surgery, patient unfit for filtration surgery. Majority of secondary open angle glaucoma, pigmented glaucoma, pseudoexfoliation syndrome, juvenile glaucoma, angle recession glaucoma. The laser surgeon may suffer from subtle change in color vision on long-term exposure to argon blue light. Laser surgeon, in note they have mentioned that the laser surgeon may suffer from subtle change in color vision on long-term exposure to argon blue light. So the surgeon also needs to be very careful. Contraindications: narrow angle, poor visibility due to corneal opacity or hazy media, congenital glaucoma, inflammatory glaucoma, neovascular glaucoma, aphakic glaucoma with vitreous in antechamber, failed previous 360-degree ALT, tired laser trabeculoplasty. So, general steps: first, explain the procedure. Second, signing the informed consent. Then meiosis, 1 drop hydrocarbon nitrate. Obviously, first you should take a consent. Then they have mentioned that it should be written informed consent. Explain the procedure, explain the need of the procedure, then take the written consent. Then meiosis, 1 drop hydrocarbon nitrate 2% at 15-minute interval starting 2 hours prior to ALT. Anti-glaucoma medication, 1 drop brimonidine tartrate 0.15 to 0.2% or epinephrine 1% 1 hour prior to ALT. Then anti-glaucoma medication, 1 drop brimonidine tartrate 0.15 to 0.2% or epinephrine 1% 1 hour prior to ALT. Anti-glaucoma medication which are there. 1 drop of brimonidine tartrate 0.15 to 0.2% or epinephrine 1% 1 hour prior to ALT. Then anesthesia. Anesthesia, 1 drop topical proparacaine hydrochloride 0.5% few minutes prior to ALT. Peripulpal injection lignocaine hydrochloride in nystagmus and uncooperative patient. Comfortable sitting on revolving stool. Steady fixation, apply head strap and adjust fixation target. Insert appropriate laser contact lens, see table 11.1. Following lenses are suitable for ALT due to incorporation of either argon or diode bonded anti-reflective coating or YAG bonded enhanced anti-reflective coating. Rich trabeculoplasty laser lens, Goldmann streamer lens, then Latina SLT selective laser trabeculoplasty gonio laser lens, Optima magna view gonio laser lens, Pollock iridotomy gonio laser lens. Bigger button is for iridotomy and the smaller button is for SLT or ALT. Room illumination, darkened or semi-darkened, adjust the slit. Now in note, in small letters they are mentioned here, ALT or SLT is possible if the trabecular meshwork is visible clearly and at least 180 degree of the angle is open. However, narrow angle can be deepened by either of the following procedure alone or in combination performed ideally 1 to 2 days prior to ALT or SLT. NT-YAG argon laser iridotomy, chapters 12 and 13 that we'll see later on. Argon laser peripheral iridoplasty or gonioplasty. Diode laser 810 nanometer trabeculoplasty offers the same therapeutic effect as ALT. The procedure and steps are essentially similar. However, it causes less disruption of the blood aqueous barrier, less peripheral artery sinus key formation, and less post-laser burn pain. The diode laser parameters are 1 power 800 to 1200 milliwatt, exposure time 0.1 second or 1.2 second, 0.1 second or 0.2 second, spot size 75 to 100 micron. However, the spot size can be reduced by Pollock lens 65%, Rich lens 70% and Optima magna view lens 77%. End point of optimal effect, blanching or tissue whitening. Bubble formation does not occur with diode laser. ALT technique proper. Parameters: energy 400 to 1200 milliwatt, exposure time 0.1 second and spot size 50 micron. Number of laser burns: single session schedule 100 burns over entire 360 degree. In single session schedule 100 burns over entire 360 degree. Double session schedule 50 burns over 180 degrees in 2 sessions at 4 weeks interval. Interval between the 2 sessions 4 weeks. Then there is a schematic drawing illustrating ALT laser 50 micron burns and significance. That this picture I'll add at the end of this video. Pictures of the videos will be added at the end of this video. Then 1 and 2, blanching or tissue whitening with no bubble formation, ideal. 3, the aiming beam is ill-focused, the laser focus is oval with blurred edge, unacceptable. 4, minimal or small bubble formation, acceptable. Slight discoloration, acceptable. And 6, large bubble formation indicates too high power setting, unacceptable. Schematic landmarks: A, Schallweiss line, B, non-pigmented trabecular meshwork, C, pigmented trabecular meshwork, D, scleral spur, and E, ciliary band. End point of optimal energy effect, blanching or tissue whitening with minimal or no bubble formation. Large bubble formation indicates energy level is too high. If the tissue reaction is inadequate, increase the energy or power by 200 milliwatt until optimal end point is achieved by least power. Site of focus: at the junction of the anterior non-pigmented and posterior pigmented trabecular meshwork, figure 11.2 that I'll add later on at the end of this video. If properly focused, the laser focus will be perfectly round with a clear-cut outline. If the aiming laser beam is not perpendicular to the laser lens surface, the spot will be oval with blurred margin or blurred edge. Initially, the mirror is placed at 12 o'clock to view the inferior angle. and the laser bursts are spaced 150 micron apart, that is at an interval of G bond widths. Then post-laser advice. Post-laser, there can be increase in the IOP, there can be inflammation. So these two things need to be taken into consideration, and accordingly we should give anti-glaucoma medications and topical steroids. So control of intraocular pressure rise. Acute elevation of intraocular pressure, that is more than 10 millimeter of mercury, occurs in 10.15% of the patients, only 10.15% of the patients, within 2 hours post-laser. 1 drop brimonidine tartrate 0.15 to 0.2% or apraplenidine 1% is topically applied immediately after ALT. Pre-ALT, all anti-glaucoma medications to be continued for 3 weeks. Control of inflammation, topical steroids 4 times daily for 7 days only. Complications, worsening of primary open-angle glaucoma, transient corneal bone, iritis, peripheral anti-cyanic pass. Posteriorly placed bones result in pass formation and early post-laser IOP spikes. Hyphema trabecular hemorrhage, it is stopped by increasing pressure on the eyeball with the gonio laser lens. Thank you. Now next I'm going to talk about the selective laser trabeculoplasty. Now selective laser trabeculoplasty. Selective laser trabeculoplasty or selective laser trabeculotherapy is performed with Q-switched frequency doubled Nd:YAG laser 532 nanometer. It has replaced Argon laser trabeculoplasty ALT due to lack of damage to the trabecular meshwork. Table 11.2. That I'll add later on at the end of this video once again. Mode of action, it selectively targets the melanin granules within the cells of pigmented trabecular meshwork TM. Disruption of the melanin granules causes cell death, termed as selective photothermolysis. There is no structural or photocoagulative damage to the trabecular meshwork TM. Eliminates scarring seen in ALT, which is responsible for reduced aqueous outflow. Indications, again same. Primary open-angle glaucoma, majority of the secondary open-angle glaucoma, and failed previous Argon laser trabeculoplasty. One more indication. So, first indication, primary open-angle glaucoma, that is inadequately controlled with maximum medical therapy MMT, with poor patient compliance as a choice prior to the filtration surgery, patient unfit for filtration surgery. Majority of secondary open-angle glaucoma, pigmentary glaucoma, pseudo-exfoliation syndrome, juvenile glaucoma, angle precession glaucoma, and failed previous Argon laser trabeculoplasty ALT. Contraindications, narrow angle, poor visibility due to corneal opacity or hazy media, congenital glaucoma, inflammatory glaucoma, neovascular glaucoma, aphakic glaucoma with vitreous and AC, anything that is blocking the trabecular meshwork, that is vitreous and AC, neovascular glaucoma, inflammatory glaucoma, congenital glaucoma, poor visibility, obviously then narrow angle. General steps of selective laser trabeculoplasty. Explain the procedure. Signing informed consent. Myosis 1 drop pilocarpine nitrate 2% at 15-minute interval starting 2 hours prior to SLT. Anti-glaucoma medication 1 drop brimonidine tartrate 0.15 to 0.2% or apraplenidine 1% 1 hour prior to SLT. Then tablet acetazolamide 250 mg half hour before SLT. Anesthesia 1 drop of topical proparacaine hydrochloride 0.5% few minutes prior to SLT. Peripulvar injection lignocaine hydrochloride in nystagmus and uncooperative patient. Comfortable sitting on revolving stool, steady fixation, apply head strap and adjust fixation target. Insert appropriate laser contact lens, table 11.1 and figures 11.1 A to E. Following lenses are particularly suitable for SLT due to incorporation of YAG bonded enhanced anti-reflective coating, Latina SLT gonio laser lens, Ocular Magna View gonio laser lens, Horlock iridotomy gonio laser lens. Bigger button is for iridotomy and the smaller button is for SLT ALT. However, in addition to the above lenses, which trabeculoplasty and Goldman's Steiner lenses are suitable for Argon laser trabeculoplasty. Now table 11.1, specification of laser lenses used in SLT ALT, courtesy Ocular Instruments, value WA USA. Then laser lens type, image magnification, laser spot magnification factor, LSMF, laser spot magnification factor, field of view indication. Platina SLT gonio lens, image magnification 1 time, laser spot magnification 1 times, field of view 130 degree, indication SLT ALT, ocular magnum view lens, image magnification 1.3 times, LSMF 0.77 times, then field of view 160 degree, indications SLT ALT, then reach trabeculoplasty lens, image magnification 1.4 times, then laser spot magnification factor 0.70 times, field of view 80 degree, and indication only ALT. Goldman 3-minute Pollack iridotomy 0.93 times magnification, laser magnification factor 1.08 times, field of view 140 degree, then indication only ALT. Gonio laser lens, Pollack iridotomy gonio laser lens, image magnification 1.5 times, laser spot magnification factor LSMF 0.65 times, field of view 160 degree, and indications SLT and ALT. SLT technique proper. Room illumination should be darkened or semi-darkened, then adjust slit lamp beam. Then SLT technique proper parameters, energy 0.6 to 1 millijoule per pulse. Now energy is watt, that is power into exposure time in seconds here in case of the laser. So it is 0.6 to 1 millijoule per pulse. Pulse duration is 3 nanosecond and spot size is 400 micrometer to avoid bubble formation. Now number of laser burns, 50 single short pulses 3 nanosecond sprayed over 180 degree of the trabecular meshwork, inferior or nasal quadrant. Then 3 endpoint of optimal energy effect. There is no endpoint like blanching or tissue whitening or bubble formation as seen in Argon laser trabeculoplasty, that is ALT. Side of focus, the shots cover entire height of the trabecular meshwork. Initially, the mirror is placed at 12 o'clock to view the inferior angle. The laser burns are placed confluent without overlap. Okay, so figure 11.2, laser trabeculoplasty. 1 Chalvez line, 2 non-pigmented trabecular meshwork, 3 pigmented trabecular meshwork, 4 sclerals per 5 ciliary body band. Then Argon laser trabeculoplasty, 50 micrometer laser spots at the junction of the pigmented and non-pigmented trabecular meshwork. In case of the Argon laser trabeculoplasty, 150 micrometer apart. Right is selective laser trabeculoplasty, 400 micrometer confluent laser spots covering entire height of the trabecular meshwork. Okay. So table 11.2, comparison between ALT and SLT. So procedure, type of procedure is Argon in selective laser trabeculoplasty, frequency doubled NTR. Then energy 500 to 1000 milliwatt ALT, SLT is 0.6 to 1 millijoule. Then spot size is 50 micrometer, here SLT 400 micrometer. Then number of laser shots 50 or 100, here 50. Pulse duration exposure 0.1 second, here it is 3 nanosecond, very short duration. Endpoint blanching minimal or no bubble formation, no blanching, no bubble formation in SLT. Site of focus in ALT is at the junction of the pigmented and non-pigmented trabecular meshwork. Site of focus in SLT, it is entire height of the trabecular meshwork. Then tissue damage, structural and photocoagulative damage results in crater and scarring, and in ALT no damage to trabecular meshwork. Contact laser lenses in ALT called Goldman 3-mirror or 1-mirror reach lens. Then in SLT it is Latina SLT gonio laser lens, Pollack iridotomy gonio laser lens, and ocular magnum view gonio laser lens. Repeat ALT or SLT. In ALT it is ineffective. Repeated procedures are not done in ALT. Once it is done, if it fails, go for SLT. And SLT potentially repeatable several times. Post laser advice. 1. Control of the intraocular pressure rise. Acute elevation of the intraocular pressure more than 10 millimeters of mercury occurs in 10 to 15% of the patients within 2 hours post laser. 1 drop brimonidine tartrate 0.15 to 0.2% or apracronidine 1% is topically applied immediately post SLT. Then second, pre-SLT all anti-glaucoma medications to be continued for 3 weeks. Then control of inflammation, topical steroid 4 times a day for 7 days only. Intraocular pressure checkup after 1 hour and 3 hours of laser treatment. Then repeat SLT in remaining 180 degree of the trabecular meshwork may be undertaken after reassessment. Then complications, anti-tumor inflammation is onset universally in all cases. Occasional negligible pain, redness and discomfort post-laser IOP scan. So complications can be similar to the ALT, but here less commonly seen in SLT. And the videos regarding the SLT and ALT from colonoscopy, www.colonoscopy.org, I'm going to add. I'm also going to add some figures from this book and tables, so you can understand it better. You can go through them. And some short videos from the YouTube related to the Argon laser trabeculoplasty and selective laser trabeculoplasty. So thanks for listening to me patiently. Thank you.
Laser trabeculoplasty has been in our armamentarium for many years now. And we'll talk in this brief discussion about argon laser trabeculoplasty, or ALT, and selective laser trabeculoplasty, SLT. But there are others, diode laser, micropulse diode laser, and what an individual is going to perform is going to depend on where they practice. Argon laser trabeculoplasty was introduced in 1979, so it's been around for quite some time. The mechanism appears to be an increase in trabecular outflow. It's therefore less effective if opening the channels into the episcleral veins is not going to be that helpful. For example, if somebody has a pressure of 12, I think doing trabeculoplasty is wishful at best. But it works, like most things, works best for people whose pressures are a little bit higher than the normal range, in 20s, and the goal is to get it down 20% or 15%. The exact mechanism is not really known. It feels now that the laser energy stimulates a release of chemical mediators that modify the trabecular meshwork. There's an increase in monocytes and macrophages. It's usually used in open-angle glaucomas. Obviously, one needs to see the trabecular meshwork to perform this. So primary open-angle glaucoma, exfoliation syndrome, pigmentary are the usual situations in which this laser is used. Exfoliation and pigmentary have a lot of pigment, and so the laser may be more effective in those conditions. In most practices, it's used after an attempt of medical therapy. So maybe rather than adding a third drop, one would move on to trabeculoplasty. It's helpful for patients who have difficulty adhering with their medical regimen. Seems less likely to work in things like aphakia, angle recession, inflammatory glaucomas, developmental glaucomas, and juvenile glaucoma. And really shouldn't be considered in things where the angle is closed, obviously, neovascular, the ICE syndromes, other angle closures. And as I said earlier, in individuals where the intraocular pressure before trabeculoplasty is near episcleral venous pressure. Its effect is about the same as adding one drop. Before treatment, most will treat with an alpha-adrenergic agonist like bromonidine. For ALT, one uses argon green or blue-green laser energy delivered through a 3-mirror lens, such as the Goldmann lens on the left there, or the Rich lens on the right, which has little magnifiers built into it. 50 micron spot, duration 0.1 second, and power is titrated from 200 to 1200 milliwatts. And one can either do 180 degrees or 360 degrees. I think since SLT, ALT has really dropped off in its use, it is sometimes preferable in individuals like pigmentary patients who have tons of pigment in the angle. I might do a 180 argon laser trabeculoplasty instead of SLT. One aims at the junction of the pigmented and non-pigmented trabecular meshwork, as you can see there, and the end point is blanching or small bubble formation. SLT is done with a Q-switch frequency double YAG laser. Again, the lens is a 3-mirror lens, 3-mirror style lens, Goldmann style lens. The Latina lens on the left here is designed for trabeculoplasty, but the Goldmann lens also works. The spot size is fixed. The duration is fixed. So really all that's adjustable is the power, which is between 300 and 1000 millijoules. And the end point is these champagne bubbles, as you can see here. So one can do 50 confluent spots. The spots are large, over 180 degrees, or 80 over 360 degrees. Afterwards, check the pressure after an hour or two. For ALT, I would still use prednisolone. I tend not to use it for SLT. And then follow in 6 to 8 weeks. Complications are uncommon. One might have transient elevation of intraocular pressure, particularly if there's a lot of pigment in the angle, mild inflammation. Peripheral anterior synechia can develop, particularly with the argon laser and trying to treat somebody whose angle is very, very narrow. And so this is someone who had trabeculoplasty performed. Their angle is narrow. You can see synechia periodically where the iris was spot welded to the trabecular meshwork. So this can either be an angle that's quite narrow or aiming way too posteriorly with too much energy. The glaucoma laser trial took place in the 1990s, compared argon laser trabeculoplasty to medical management, which at that time was timolol. In the first 2 years, the laser-treated eyes had lower pressures and fewer added medications than the timolol eyes. However, the laser eyes gradually lost some of that effect and required the addition of medication. It has less impact on our practice today because timolol is no longer the first line of therapy for most ophthalmologists, and most people don't use argon laser, but it is one of the main randomized controlled clinical trials that someone might ask about. So the key points: trabeculoplasty stimulates aqueous outflow through the trabecular meshwork, has an effect similar to adding a drop, is used in the open-angle glaucomas. Risks are really quite small, mostly transient pressure rise. So it's a technique most of us will use fairly frequently, and it's something you really need to be comfortable using.
Trabeculoplasty is a laser treatment for primary open-angle glaucoma. The laser is used to treat the trabecular meshwork through which the aqueous humor drains. In this procedure, the eye is numbed with eye drops. A special laser lens is placed on the eye to help control the direction of the laser beams. The laser burns a small area in the trabecular meshwork, opening up the drainage canal. About 50 spots over 180 degrees of the meshwork circle are treated in one therapy. The original laser trabeculoplasty procedure applies argon laser of 514 nanometer wavelength on half of the meshwork circle in one treatment. Although a second treatment can be performed on the other half of the circle, the procedure is generally not repeatable as it causes extensive scarring of the trabecular meshwork. The newer technique, selective laser trabeculoplasty, or SLT, uses a solid-state laser of 532 nanometer wavelength. The pulse energy of SLT is about 100 times lower than the traditional argon laser trabeculoplasty. SLT selectively targets pigmented cells while leaving the rest of the trabecular meshwork tissue intact. For this reason, it can be applied to 360 degrees of the meshwork in one treatment and is considered safe to be repeated. In terms of efficiency, the two techniques return similar results in lowering intraocular pressure. Laser trabeculoplasty treatment is effective in about 75% of patients. The effect may take a few weeks to kick in and can last for several years.